Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. Thank you for joining us for the latest in our series of Policy Spotlight discussions. Policy Spotlight is a series of virtual events Health Affairs launched last year, featuring in-depth conversations with influential health policy experts. We featured CMS Administrator Chiquita Brooks-LaSure, CMS Innovation Center Director Liz Fowler, and most recently, we had Deputy Administrator and Director of the Center for Medicare, Mina Seshamani. If you missed these or other events, you can see them all on our website. They've all been recorded. If you're watching us live today, you can use the Q&A box in Zoom to submit questions. I can't promise I'll get to them all. If they're shorter and relevant to a larger audience, I'm more likely to be able to fit them in. I'll get to as many as I can. As I noted with our prior events, this is being recorded and we'll post the video to the healthaffairs.org event page within a few days. Today, I'm joined by Carole Johnson, Administrator of the Health Resources and Services Administration, or HRSA, an agency within the U.S. Department of Health and Human Services, which is responsible for providing equitable healthcare to people who are geographically isolated and economically or medically vulnerable. HRSA has a broad array of programs addressing federally qualified health centers, primary health care, oral health, maternal and child health, and more. We'll get into as many of these areas as we can, but the purview of HRSA is so large, I know we won't be able to cover it all. HRSA had a $12.1 billion appropriation in fiscal 2021. So there's a lot of programs in there. I'm so pleased to be able to speak today with Carole Johnson, the HRSA administrator. She was formerly the commissioner of the New Jersey Department of Human Services, worked on the Domestic Policy Council in the Obama White House, has been on the staff of the US Senate Special Committee on Aging. And there's even more, but I think that's a good start. You have a great broad background, perfect for the kind of broad responsibility of the HRSA administrator. So as I welcome you to this policy spotlight, I'll just start by asking you to say a little bit about your priorities for HRSA. And then I'll begin with some questions that'll cover as much ground as we can. Ms. Johnson, welcome.
Thanks so much, Alan, and thank you for the chance to be here with you today. It's really great to connect with all my friends and colleagues in the health policy community. You know, for folks who don't know HRSA as well, we are, as you mentioned, an agency that's really organized around ensuring that we get access to the services and supports that traditionally underserved, under-resourced, geographically isolated communities need. And we really think of ourselves as a health equity agency that's all about improving health outcomes. We deliver healthcare services through the Federally Qualified Health Center program to close to 30 million Americans. We deliver healthcare services through the Ryan Wright program to about 500,000 Americans who live with HIV. We deliver infant screening services through the Maternal and Child Health Block Grant to nearly every infant born in this country. We are the Office of Rural Health Policy in HHS, and so we run substance use disorder services in close to 1,500 counties, rural counties across the country. So we have a pretty big footprint when it comes to direct healthcare services, but we also are the workforce arm of HHS, and we invest in building the primary care workforce, building the mental health and substance use disorder workforce. We're the home of the National Health Service Corps that provides loan repayment and scholarships in return for clinicians' commitment to serve in the communities that need them most. We're the home of the 340B program, which is a wonky title for a drug discount program that provides billions of dollars in support to the healthcare safety net. So as you said, we are a broad and diverse agency with many things on our plate, but among my top priorities are the priorities that I share with the Secretary and the President, which are reflected in the budget release today, which is really about addressing the critical mental health needs of individuals across our country. And that is, for us, both about the mental health needs of individuals in underserved communities, as well as really focusing on maternal mental health and children's mental health through our maternal and children's mental health investments. And in addition, really, again, the Secretary mentioned this morning in our budget rollout press briefing, the critical need to close the unacceptable disparities in maternal health outcomes, and the fact that Black women are so much more likely to die either in childbirth or in the year postpartum. When we have tools that we can use to help address these gaps, which really are about both the services we provide and the way we organize them and the way we ensure that we overcome structural barriers, and that we ensure that women's voices are heard in the healthcare system. And then, there is no one who works in this space right now who wouldn't say a critical priority is workforce, supporting the people that are in the workforce today, growing the pipeline, diversifying the pipeline, and ensuring that we're getting people, encouraging people to practice in the communities that need them most.
That's a great introduction. Let me just start with something that's been on my mind, which is I've had a number of these policy spotlights and have heard from pretty much everyone in the administration about the important focus on equity. You mentioned that equity is sort of in your title already. So my question is, what's changed? What's different for HRSA having a secretary and a president who say we're focused on equity than a HRSA for any administration where that's already the goal?
Yeah, I think that's a great question, and I would say it's a seismic change. So we are the resources that have been provided to us historically have always been about serving underserved communities and reaching rural communities and geographically isolated communities. But those were sort of a function of the statutory obligations. What we are doing now is really focusing in a targeted way about how we can get to better outcomes and better equity in access to services by changing the game on the ground. So in maternal and child health, you'll see in the budget we released today, we have new sizable investments in growing the midwife workforce, in growing the doula workforce, in really thinking about how we build the supports and services that individuals need to be able to make sure their voices are heard in the healthcare system. We have new investments in community health workers, in peer supports, in people with lived experience, which is a thing that we have been doing in the Ryan White program for a long time, but we are making sure that we are learning those lessons and bringing it across the host of workforce work that we do. We also, as part of the pandemic, we had the opportunity to really invest in community-based organizations for the first time. So we have made probably close to $400 million worth of grants to community-based organizations across the country to work on and address the information needs that people have when it comes to making their choice about vaccination, and to help overcome vaccine hesitancy by allowing trusted messengers in the community to have the support they need to be able to connect with individuals and answer their questions and help them make informed decisions. So it's not just about where we are, it's about how we are, right? We're not just in underserved communities, we're thinking differently about how we do our work in underserved communities.
So as one of the questions I always bring to HRSA is that I kind of grew up in Medicaid. That's where my experience is. And the payers are over there. You have these targeted programs to address some of these challenges. We will talk about some number of them, but let's take the example of workforce. You identify shortage areas, you invest in health centers. What's the role of HRSA relative to those that are paying claims that also spend billions of dollars that can go out and either reinforce existing disparities in access or help overcome them? How does your focus on equity translate through the other parts of HHS so that there's a coherent approach to addressing these issues?
Yeah, I think it's a great question. I mean, you mentioned that I had been Human Services Commissioner in New Jersey, and I had sort of under one roof in New Jersey a whole host of programs and services, including Medicaid and SNAP and aging services, mental health and substance use disorder. And unless you are, what is clear to me there, and I'm sure it's clear to you from your Medicaid experience as well, is unless you're conscious about how you're actually going to deliver on Medicaid benefits, just creating the benefit isn't good enough in and of itself to actually move the needle on equity. And so, for example, we really, partnered really closely with our health department in New Jersey to recruit and train community-based doulas, and then build a Medicaid benefit with their input to be able to ensure that community-based doulas could participate in our Medicaid program. Unless you're actually thinking about things holistically, and unless the individuals that you're trying to bring to the table are part of the conversation, we might have built a doula benefit just like we built benefits for, other services. We built some benefits for tobacco screening services. We might have done it exactly the same way, but we needed those individuals to be at the table to tell us, well, we have a different experience when it comes to, we don't have the same experience billing. We don't have the same experience partnering with large organizations, and honestly, we don't want to. We want to be we want to be a community-based entity. And so, really thinking about how we leverage our discretionary funding dollars to create the model and the backbone organizations and the kinds of supports that allow us then to ensure that we can succeed when we build long-term payment structures in Medicaid. It's always been a little bit of folks looking at the other person saying, well, if only there was a Medicaid benefit, well, if only there was a training pipeline. What's so nice about this administration, what's so nice about the Secretary's commitment and the President's commitment is that we're all charged with sitting together and figuring it out together. It is an incredible experience to be able to partner so closely with CMS and SAMHSA and HRSA to really think about how we do these things in a coordinated way so that we're maximizing our discretionary dollars to succeed on our entitlement investments.
I want to focus in a little bit on as you said, workforce. And you oversee the health center program. You have the Bureau of Primary Care. There are workforce shortages that are not about primary care. They're about specialty care and specialty access. There are payment streams for federally qualified health centers, both through direct grants and through payment policies through Medicaid. All of these sort of, again, are looking at different parts of the issue of equitable access. I wonder if you could say a little bit more. First of all, I've already gotten what I knew would be the first bunch of questions, which have to do with payment policies around FQHCs. I don't think I've ever had a session where FQHCs are the topic and the first question in isn't, when are we updating the payment policies around FQHCs? So I have to ask you that. But more broadly, how do we look at the balance of health centers and non-health center providers in terms of providing access, the balance between primary care and specialty care, and the leverage that you all have at HRSA to take these issues on jointly?
Yeah, I mean, one of my, one thing that is just really exciting for me to be in this role is that I had the opportunity to work in HRSA early in my career in the Health Professions Bureau, when we really were trying to take all of our sort of Title VII, Title VIII programs around the passage of the Affordable Care Act and figure out how to make sure we were maximizing our opportunities for primary care. In part because we knew CMS has a very large GME pipeline for a host of specialties, and there's a lot of incentives to train in those specialties. What we have in our house in HRSA, and where our discretionary dollars can help create different incentives, is by really thinking about how we help training programs and medical schools focus on and give people exposure to primary care. We have our Teaching Health Center program, GME program, that was a product of the Affordable Care Act, where we are creating residencies that happen in the community. So where your rotation is, you still have your hospital rotation, but you're also rotating into, places like shelters for individuals experiencing homelessness or other community-based sites, so that you get that experience of what community-based services and care looks like. And then we have the National Health Service Corps, which is really our incentive program to help people, to give people loan repayment in return for practicing in underserved communities. And that's a place where we are increasingly using that program to support behavioral health providers, so that we can get clinicians into the communities that need them most. And then the other program that we run at HRSA is the Children's Hospitals GME program, to recognize the fact that those are providers who aren't going to have the same access to the Medicare GME pool. And so we're able to train to help support, close to half of the training of pediatric providers and pediatric specialists through our GME program. So it's not all specialists, and we don't have the discretionary resources to train all specialists, but we have the discretionary resources to meet those gaps, and to create those incentives where we know, with some more exposure, with well-supported programs in the schools and residencies, that more people would choose primary care, or more people would choose to go into pediatric services, or more people would choose to go into behavioral health services, if we can create strong programs, really make sure that there's a preceptor there to be able to do the training, that they're not overworked, so that we can actually get you a site where you can do your clinical placement. Those kinds of things take work and take some diligence, and that's what our workforce programs are really focused on.
I want to return to one part of, since I asked you sort of a 7-part question, since there are always questions about prospective payment, value-based payment in health centers, in particular in the FQHC program. Can you talk some about, and I'm always struck, let me just say, I'm always struck when we talk about payment. There's a whole history here of payment methods and how we got here. And maybe if you can not just sort of talk about where you want to go, but put it a little bit in the context of the goals of prospective payment and the future, and the goals of transition towards value-based payment models for FQHCs.
Yeah, I think one of the things that we all take great pride in and need to recognize is the role that federally qualified health centers have consistently played in being that healthcare safety net. I had the opportunity recently to visit one of our health centers that is actually a health center for individuals experiencing homelessness program in Ohio, where that's not just a clinic on the street that you drop in and you get your blood pressure checked out, or you go when you think you have symptoms. That's a clinic that's out on the street, reaching out to individuals who are experiencing homelessness and might lose their foot to diabetes, or are experiencing homelessness because they're LGBTQ kids and their parents are not accepting of them, and they're now looking for a place to live. And so that's a program that is doing that critical on the ground work. That's just so much my passion, is that health centers are not just the bricks and mortar walls, they are the outreach into the community. And we depended on that during COVID, right? During COVID, we went to health centers and said, you need to be the hub for vaccination. You need to be the hub for testing. You need to be the hub for masks in this community. Now we're asking them to be testing and treating hubs. And we've done, 20 million, they've done 20 million vaccines as a result of that. And so there is a different role that they play, and the Affordable Care Act recognized that with some payment updates. There's always a continued conversation about, how people get paid and what they get paid. But the interesting dialogue I think we're having now is what does value-based payment look like for safety net providers, not just FQHCs, but rural health clinics, safety net hospitals, and the like. And they're not the kind of entities that have upfront investment dollars. They're not the kind of entities that really have tons of experience with downside risk. They have tons of experience in collecting data, because we ask for a lot of data from them. But there's, I think there's work to do to figure out what the next iteration of payment looks like here.
Yeah, we published a paper recently that showed that as you move into downside risk models, the FQHCs are quickly less willing to participate. So if the world and if the word from CMS is we want people in systems of care, and one of the motivations for creating systems is bearing risk, how do you get health centers ready for a world where there are payment models that are going to have to include some sort of, or potentially will have to include some sort of downside risk?
Yeah, well, you've had the opportunity now it sounds like some of your prior sessions have been with my colleagues at CMS, who are folks who are very, very cognizant of what it takes to deliver care in these communities. And we've had lots of conversations about these scenarios. So, I think there'll be work to be done depending on, what path CMS goes down, but they won't go down that path alone. We'll be part of that conversation, because one of the many terrific things about this administration is that the partnerships between CMS and HRSA are much stronger than they've probably ever been. And so that's why we're at the table, and our leaders are at the table across our organization to help talk through with CMS what that could or should look like.
I received a question, and it's a variant on one that's on my mind. As the health system in the last 5+ years has started talking a lot more about social determinants of health, that's not a new concept to a lot of the providers that HRSA has a relationship with. But we are now talking about different sets of tools designed to measure the existence of unmet social need, Z codes. We've got payment models, again, that are designed to reward maintaining health, which may warrant investments in some of these social determinants. So what would you say HRSA and the community providers you work with has learned from a really long history of paying attention to social determinants that might be helpful for other parts of the health system that have only come to these issues somewhat more recently?
Yeah, it's such a great question. And I like to say that, like, Ryan White and health centers have been doing social determinants since before it had a name, because that is sort of who they are, baked into what our expectations of them are. And I won't pretend to speak for all of them, but what I've clearly seen over the years is that partnerships are so critical, and our table of what we care about that gets funded gets bigger, right? Because we need to make sure that the HIV housing dollars at HUD get appropriated in the way we want them to, in the same way that we worry about HRSA's funding for Ryan White, because that is a critical part of our services and supports being able to be well delivered and people to be in safe housing. So, what the social services safety net looks like is part of our agenda as well, so that we can ensure that the people that we serve thrive. I personally am of the belief that childcare is like what the Affordable Care Act was 12 years ago, right? Like, this is the time, this is the moment when we need to make sure that this is what Build Back Better was focused on, right? Like, making sure that those critical services that people depend on, those aren't just about making sure that there's economic development and economic opportunity. So when someone has someone in childcare, they're also about the health and well-being of parents. And that's, we have to think holistically about what the set of services are that we're focused on when we think about people holistically.
A question I got in from a listener about social determinants, I'm going to take it and build on it slightly, because I think it captures a philosophical or design issue that I'd love to get your reaction to. But when I think about many of the HRSA programs and approaches, they're sort of public good enterprises. They're designed to help a community. They're focused on populations. A lot of the healthcare system is built around a much more privatized model, where you're in a health plan or you're in an ACO, and we expect the infrastructure investment necessary to meet needs to be made within that private space. So the question that was asked was, at what point will efforts to create referral platforms around social determinants or other connecting tools between providers and community partners be considered public good as opposed to proprietary? And I don't know if you can answer that specific question, but I want to use it and my introduction to the question as an opportunity to sort of ask about the harmonization or the competition or contrast of approaches for building, if you will, public good infrastructure as opposed to privately developed infrastructure.
It's a really interesting question, and I think that it's challenging, right, to be a healthcare provider and to try to do these things, and you see patients under many different plans, and they have different tools available, and how we make that workable for providers so that they can best serve the folks that they're serving is critical. I don't know that I have all answers to the question, but we have been thinking about how health centers that serve large populations and have many sort of satellite sites might be ways to think about shared resources here or common platforms.
I'm going to walk through a number of programmatic areas just to draw them out, partly because I think, again, the breadth of HRSA is so interesting, but also to get a sense of where you're going. I'll start with one that you mentioned at the outset, which is behavioral health and the tie to maternal mental health, child mental health. This is such a big topic. We could spend all of our time on it. But again, from the perspective of HRSA, why don't you say, if you could, a little more, I'd love to hear a little more, if you could, on what the agenda is here. It seems like the gap between where we are and where we need to be when it comes to mental health is so large. And you did mention at the outset some issues around substance use disorder. Behavioral health, of course, encompassing both sort of traditional mental health issues and substance use issues. How do you start to tackle a problem where the gap is so large?
Yeah, I think it's such a great point, and I think HRSA may not be the first place that comes to mind when you think about how we're going to tackle the behavioral health crisis, but it is for me because we have historically been a primary care-based agency. And I think the definition of primary care is rapidly changing, and that the definition of primary care needs to be inclusive of mental health care. It isn't going to be the case going forward that clinicians are going to be able to deliver on ACO metrics or other things for physical health outcomes if they don't have the capacity or the time or the space to consider individuals' well-being. So I think we need to bake mental health services and needs into primary care, and then we need to make sure that we have all the full continuum of services across crisis and emergency response and SMI services and the like. And so we're doing a couple of things here that I think of our work in behavioral health in kind of three buckets. One is the services we provide, right? So we provide mental health and substance use disorder services through Ryan White. We provide it in many health centers, not all. We're going to continue to work on those issues. And we provide, we have been a place where Congress has asked us to, and we have grown our footprint substantially on substance use disorder treatment in rural communities because of the longstanding rural work that HRSA has done. So services are a critical part, growing that work. Second is really how do we use all of our primary care training tools to expand access to mental health services, to make sure that primary care providers who we're putting through training programs, who we're encouraging to practice in underserved communities and the like, have exposure to and knowledge about how to identify and treat primary care practice. And we're doing this in sort of lots of interesting ways, including building tracks into our primary care training programs, but also through our maternal and child health block grant, we're increasingly providing training to pediatricians, maternal health providers, and making sure that they have the tools to be able to screen for depression, anxiety, and the like. And then we're providing telehealth, teleconsult capacity, so they in real time can talk with mental health experts about a patient who's in front of them. So what we're seeing over time, anecdotally, our evidence is beginning to build up, that the calls to our teleconsult lines are more complex. And so what we take from that is that the primary care providers are getting more and more comfortable with some of the cases that they're seeing, and that the calls are really the teleconsults are really focused on more complex mental health conditions, where we're able to work with the provider to refer people to others in the community. So services, training, baking mental health training into primary care, and then building the mental health and substance use disorder workforce. So we do this through direct training investments in those programs. So we're training psychologists, we're training clinical social workers, we are training marriage and family counselors, but we also are training community health workers and peer supports and others who we know are the people with lived experience, who are connected to individuals in the community who often, we hope, based on the way we structure our investments, we often hope look like the communities that they serve and are able to really engage with people and get them connected to care, and then are really important to retaining people in care. So using our tools to train the workforce for mental health and substance use disorder treatment, and then using tools like the National Health Service Corps to encourage them to practice in the communities that need them most. So again, our sort of buckets are services, baking mental health and substance use disorder into primary care, and then training the behavioral health workforce.
So my Medicaid origins are just keep bursting out, and I'm sorry if that's a problem, but you too, exactly. And I'm sitting here thinking, okay, and where's the payment side of this to sustain these investments? I'm thinking, if I remember right, and it's been some time, so I may not, of the quality metrics for accountable care organizations, my recollection is that there's one mental health measure. It's depression screening for the child and adult, quality measures for Medicaid, and CHIP. There's a very thin slice of mental health metrics. And so how do we take, this broad vision of primary care, including mental health, it sounds like a good direction to go, but then how do we build the other payers or the payers around the notion that when they're thinking about payment levels and what performance is, that they're reflecting that same sense of priority?
Yeah, it's a good point, I think, about, in some ways, the metrics catching up with where the world is, frankly, because if you've been a state official in the last 5 years and you haven't been focused on the opioid crisis, then you were not, I don't know what was happening, because you were focused on the opioid crisis. And if you were focused on the opioid crisis, you were trying to figure out what Medicaid leverage you had to be able to address that. And so things that we did in New Jersey, and we know other states have done lots of interesting things, but we sort of changed our Medicaid payment structure so that we could try to incentivize primary care providers to provide medication-assisted treatment. We changed our Medicaid payment structure so we could put some of these individuals, like community health workers or peers, embedded in larger practices so that they could do navigation services to help people get connected to counseling. And that's not the answer for everyone, but you see lots of things happening around the country, focused on the opioid, focused on responding to substance use disorder needs, and increasingly, I think, focusing on SMI among kids, because severe mental illness among children is, if you want to look at it just from a payer perspective, payers are increasingly seeing children boarding in EDs, and it is creating all kinds of challenges across the mental health care response system. And so we have to be able to get upstream and be able to identify who those children are, what services we can wrap around them early, how we can get them into the best clinical setting that's supportive of them, and how to support their families. And so I think that I take your point that the quality metrics and the design of payment models have to catch up with this. But in the real world, if you're a Medicaid director right now, you're thinking about mental health and substance use disorder.
That's a great answer, and I'm going to think about it And I like that a lot. Another core health issue, it doesn't have the same reach as the behavioral health topics we just described, but has some of the same segmentation and poor access and poor payment, is around oral health. Can you say a little bit more about particularly HRSA efforts to build out the workforce in this area, and how you deal with some of the licensure skirmishes that seem to be an impediment to having the workforce that we need?
Yeah, and I'll just step back for 1 second though and say, when you think about oral health, we have been spending a lot of time in our maternal and child health work focused on getting children connected to their regular sources of care post-pandemic or during this phase of the pandemic, as we're in a phase where people are returning to school or returning to work and those types of things. Kids miss far too many of their regular vaccines, and so we've had a conscious targeted effort with health systems and community health centers and schools and the like across the country to try to get kids caught up on their regular vaccine schedule. But when you think about that, I think oral health is even more challenging, just because it's such a close contact intervention that people have delayed seeking oral health care. And so our challenge in oral health has always been about education. It's always been, the critical need to figure out how to get children from underserved communities, really how to work on access, how to make sure that we were thinking about where can we connect dental services to access points. But it's even more critical now just because we've lost some time. And we really, have to focus on this issue in a targeted way, both from a prevention as well as from a treatment, really getting kids into services focus. And so, I was just having a conversation about this morning with some colleagues about how we take kind of a holistic approach here and use all our public health messaging tools to get kids re-engaged in care.
I can keep going through programs, and I will, but I want to step back and ask sort of a more organizational, maybe bordering on philosophical question about what it means to run HRSA. You have these programs that are focused on particular populations or body parts or healthcare needs. You have a broad equity imperative. You have other dimensions like rurality or health professions shortage area or underserved urban areas. When you describe these programs, whether it's Ryan White or oral health or efforts around behavioral health, how do you sort of crosswalk between the service type or the clinical care side of it and these geographic dimensions of inequity that are so long standing in this country? How do you line these two very different dimensions up when you're thinking about programs?
Yeah, and I think when we put our equity lens on, which is how we look at all of our work, it's not just geography, but it's also the demographics. Like, there are individuals from communities of color that have historically been underserved in the same way that there are geographically isolated communities that have been historically underserved. And so we try to think about the services and the people who need those services, and how we create services that are meaningful and useful in the community. So that's part of the reason why I say we were so excited to be able to fund community-based organizations for vaccine outreach this year with American Rescue Plan funding, because it allowed us to really build partnerships with trusted messengers in communities that we practiced in for years, right? So we health centers are trusted messengers in so many communities. Rural health clinics are trusted messengers in so many communities. But community-based organizations gave us, another dimension of being able to connect with people and often create jobs in the communities that we serve. We want to be sort of part of the fabric and infrastructure of the community. And so I guess I would say, I'm not sure what my philosophical answer to the question is, but I think we think about it from the people we're serving, and then geography is, institutional and structural biases are the barriers we're trying to overcome to better serve those individuals.
Oh, that sounded very philosophical to me. I'll take it. Now,
I do have a pseudo philosophy undergrad. So.
That's great. When you were in New Jersey, you, as I understand it, had Health and Human Services. So you had opportunities for bringing these various dimensions and programs together. When I asked you for an example of integration, you drew an example appropriately from New Jersey. When I ran the Medicaid agency in Colorado, the Human Services Agency was totally separate. The health department was totally separate. And there have been a lot of changes in many states. They go through cycles of combining and separating. It's interesting to watch those. But for states and localities that are not in as fully integrated a structure as you were in, and I know you'd be the first to say, just because you're under the same umbrella doesn't mean you automatically have alignment. How do you think about working with states and localities where there isn't the same organizational alignment that you had in New Jersey?
Yeah, it's a great question. In New Jersey, I had everything but the public health department. So I had all the other social service agencies and Medicaid, but not the public health agency. One of the ways I think we can help, I hope we can help, is by coordination at the federal level. So CMS, HRSA, SAMHSA, CDC, if we are coming together to you and saying to a state, you have maternal health block grant dollars, you have SAMHSA block grant dollars, you have CMS waivers, you have CDC public health dollars. You can think about how to leverage it, how to plan these dollars together in a way that will help you hit your target, better address your priorities. And we need to model that so that states, so that we have the best shot in those states where services are a little bit less or more diffuse. Because I think if we can encourage that, both model it and encourage it, we hopefully will create better outcomes. We can do convenings, right? We can pull together your maternal health lead, your single state agency, mental health and substance use disorder lead, your Medicaid lead. We can build those kinds of opportunities and platforms. In some states, everyone knows each other, but they don't really always, it isn't always a symbiotic relationship. It was real. We were very fortunate. I was very fortunate in New Jersey that everyone worked together so well, but I know that's not always the case. And I think we can use our platform and levers and encouragement, and potentially even think about other strategies to create those incentives, to create that platform for people to work together at the state level. It's not always easy. I mean, if people live in different departments, it's not always easy. But I think for us to do the kinds of things that we want to do, we need to build that. And it's not just Health and Human Services, right? Like in New Jersey, our school lunch program lived in the agriculture department. So it's really making sure that you have that broad-based relationship, and we need to build it in-house and then bring other agencies into.
Tried to weave in a good number of the audience questions. I'm going to take a moment to try to make sure I get a few more in. There's a question about whether you're planning to update the shortage designation process and formula. So much rides on the designation of shortage area. Can you say anything more about that?
Yeah, I don't have any specific updates for the group, but I will say that we're constantly looking at how we make sure that the way that we're doing our work is most reflective of what we're seeing on the ground.
Here's a related question around shortages in the dental workforce, which we've talked about some, but a specific question: would dental assistants be considered primary care dental trainees for purposes of workforce grants?
That's an interesting question. Who's eligible for what in our various grant programs is often defined by the appropriations process. And so where we can, we try to make them as flexible and open, or work with Congress to make more programs, make more providers eligible for different programs if we can. So it's very program specific and very appropriations language specific.
Here's a question I'm going to take and broaden out a little bit. Someone asked, what would you say to medical schools or hospitals that do not see the value in investing in developing community relationships or partnerships and think providing uncompensated care is enough of a community investment? And I'm just going to go slightly beyond the questioner's words. We often talk about, particularly in rural areas, the hospital being an anchor for economic development, for many other things. But if that enterprise isn't fulfilling that role, it leaves it leaves more than a vacuum, because it also consumes a lot of resources. So I don't know that you have an answer to the question, but I thought it was a great question, so I'll send it your way.
It is a great question. I think I don't have a comprehensive answer. I'll share two things. One, earlier this week, I got to talk with the deans at the AAMC who are in town, and I was their level of engagement on HRSA related community-based services. I thought we were going to end up talking about training programs, and they wanted to talk about services, and they wanted to talk about behavioral health services. So I am really encouraged by that. I think there's real opportunity, and part of it is about asking, right? And so that's my job, is to go ask and continue to do that. And then the second thing I would say is that we have just a terrific team in our rural health policy office that works incredibly hard to sort of provide all the technical support we can in rural communities. The rural hospital, the status of rural hospitals and the kind of TA they need to keep their doors open may make it hard for them to be community leaders at this point, but we are working hard with them on that. And I will say, there are many, many, many challenges that came out of the pandemic, but one thing that we were able to do is the first time we were ever able to make direct grants to rural clinics. And so I think we are, and what we hope to do going forward is build on that footprint. They've learned a lot. We've learned a lot. They've learned a lot about how to manage a grant program. We learned a lot about how to use targeted grants in rural communities to expand access to services.
In the area of maternal and child health, you spoke quite a bit about the behavioral health needs. You spoke as well about the importance of closing the racial gaps in maternal outcomes. And those are two big topics, and I certainly don't want to suggest that they don't cover a lot, but I wonder if there's more around maternal and child health that you'd like to highlight from the HRSA perspective.
Yeah, absolutely. So what you'll see in the 23 budget that came out today is our request to the Congress to let us to support us in building out our workforce training programs for doulas and midwives, so that we have community supports and the kinds of evidence-based strategies that we know help make sure that women's voices are heard, pregnant people's voices are heard in the prenatal, pregnancy and postnatal process. But also we have new resources in the budget for us at HRSA to really focus on what we call in the budget social determinants of maternal health, and really being able to focus on, how do we make sure that pregnant people have the supports they need to have a successful pregnancy. And, and so much is in that mix, whether that's, housing or transportation or food insecurity or the like. And so we're really excited about that. We hope that Congress will support that investment as well.
Another program that I am always surprised doesn't get more attention is the home visiting program. it has a strong evidence base for health outcomes as well as for economic outcomes. And I just wonder if you could say more about what lessons we've learned from that, and maybe reflect a little on why something so central and important doesn't get a little bit more attention.
Yeah, and I'm so glad you brought it up because, particularly for the health policy community that is your audience, it is such a great example of building the evidence base and then making the case to Congress and then building out a mandatory program anew, which, that doesn't happen very often. And so we now have, 140,000 folks in this program. We are continuing to grow it. Our budget proposes growing it by $67 million a year over 5 years so that we can reach another substantial chunk of the individuals we know that this could make a difference for. If we're getting nurses or social workers or child educators into individuals' home on a voluntary basis up to the age of kindergarten, we can make a difference in reducing child abuse and neglect, in improving school readiness, in improving maternal and child health. The evidence is there, the program works, and we're really, we're excited to get it reauthorized this year.
You also mentioned Ryan White early on as an example of the original approach to social determinants. Of course, the demographics of people with HIV and AIDS has changed dramatically over the course of the epidemic. Where are we now in terms of priorities for that program, and particularly the overlap with, for example, rural health needs that have always been included but weren't as central at the outset?
Yeah, and particularly for individuals who live in more rural areas who are people of color living with HIV, that's so much of what we need of the work that we're doing now is to make sure that we're helping to support individuals of color who are living with HIV, and that is both the health and services that individuals need, but the community is increasingly telling us that now that we can be at a place where viral loads can be maintained, what more can we do to help make sure that people have the best possible quality of life? When you have to live on a drug regimen, what are the kinds of things we can do to ensure that people have the best possible quality of life? And that is not only for younger people who are living with HIV, but increasingly, there's social isolation among older individuals who live with HIV who may not have the same family supports because of the challenges and discrimination that they faced when they were younger in their lives.
Well, as we come toward the end of our time, I always like to make sure I spend a little time at the end about your own career journey. We know that a lot of people listen to our policy insights, but some are coming for content. Others are just trying to understand how do you get into a seat like yours? You've had a nice variety of experiences when I read your biography at the beginning. Talk a little bit about some of the key choices you feel like you made along the way that made it possible for you to step into a role like this.
Oh, it's nice of you to ask the question. I think I have been very, very fortunate in my career of the people who I've had the opportunity to work with, and those individuals creating opportunity for me, which is all you can ever ask for. And so, I started out very early in my career on the Hill, opening mail and answering phones, and still, probably one of the best decisions I ever made. And it wasn't really even a decision, it was just an opportunity. And I was so grateful for it. And I just learned so much from that experience and really tried to soak in everything that I could, which created, and also just gave me lots of exposure to people and individuals who have helped me along the way. So again, much of my career is about luck and the people I've met along the way.
Well, everyone says that, but I'm sure it's more than that. I am curious because I worked in state government as well and have spent now a fair amount of time in Washington, D.C., though never worked in the federal government. I was struck when I came to Washington how few people I felt had really any insight into how state government worked and how state programs operated, state budgets, state staffing, all those kinds of things. I wonder
It's
if you,
so true. It's
yeah, say a
so.
little more about this and how it's affected your
And
understanding.
I am a different Fed now that I've had the experience of working in the States. As you mentioned, I worked in federal policy for years before I went to New Jersey to serve in Governor Murphy's cabinet. But when you have to make it work, and you have to make it work within the strictures you just talked about, you have to balance your budget every year. It takes longer than it should to hire staff. All of those kinds of things. I was very fortunate. The governor was incredibly supportive of us and gave us lots of opportunity and running room to try new things. But it is very, very different when you have to make it work in those kind of parameters. And I think about that all the time now as we consider how we're going to structure a grant program, how long our applications are out on the street, right? Like you don't have the bandwidth in your state to turn around a grant application in 30 days. That's just not in the realm of the possible. And so, yes, the appropriations process didn't wrap up until just a week ago, but we've got to give people time to apply for new things. So there's just a lot of things that you onboard when you run things at the state level that it sounds like you and I have had the same experience that it's been a gift to me in this role, having had that experience.
If you could say the one most common misperception of state and local capabilities or in Washington, what would you tell people? Oh, you always assume this, but now that I've been there, you might want to think twice.
I don't know. The thing I'm not sure how. Nothing's come right. The thing I would say is that boy, are people at the state level clever and just get it done kind of folks. Like it just, it kind of didn't matter what DC. I mean, there was a time, right, in the prior administration when the government might shut down and we didn't have enough of any of our response tools for COVID, and we were trying to figure out how to take care of our workforce and take care of all the individuals that we serve. And people came up with some incredibly creative solutions. There hadn't been a situation like that before, but there'd been plenty of, like, I had the same team that had lived through Hurricane Sandy, right? Like I had the same, like they knew what our response, at least how to start the conversation about our response on the ground. So I just like the people who work in state government are incredible.
Well, that's a great place to close our conversation. So, Carole, thank you so much for being my guest today on our Policy Spotlight and for sharing your insights. Thank you for what you do every day to support people who have very significant health needs around the country. And it's really been a pleasure to get to know you and speak with you in this format. To our audience, I would just say, if you like the Policy Spotlight today, visit healthaffairs.org and sign up for other upcoming events. Join our email mailing list so that you'll hear of them as soon as they are announced. Next week, we have a session with Health Affairs Deputy Editor Rob Lott speaking to David Kindig and John Malahy of the University of Wisconsin-Madison. And Sanay Magnan, a senior fellow at Health Partners Institute and former Minnesota Commissioner of Health. They're going to talk about the challenges associated with balancing investments in the determinants of health to maximize outcomes at the population level. You see the information up there on your screen. Again, to our guest, Carole Johnson, and to our audience for joining us today, thank you so much for being a part of today's Policy Spotlight, and we are adjourned.